Good morning, everybody. We're going to go ahead and get started. So today we have our two senior lectures that we're going to be having for our senior residents. Our first speaker is going to be Dr. Diana Herringer. She's going to be speaking about opiates in pregnancy and how addiction and treatment presents a unique challenge to the anesthesiologist.
Good morning, everyone. Hopefully you all have a tasty bagel and some coffee ready. So for those of you who don't know me, which I hope most of you do by now, I'm Diana and I'm a CA3. And like Dr. Leiva said, I'll be talking about opioid use disorder in pregnancy. Just a quick overview of some of the learning objectives. So hopefully at the end of this talk, you'll come away with understanding the rising prevalence of the opiate addiction in the pregnant population, understanding the neonatal risk factors that are posed for those women, understanding the opiate replacement therapy options, and different non-opiate pain adjuncts. A quick overview of my presentation. So I'll talk about a case that I had with Dr. Hawkins and how it led to this talk. I'll touch upon those learning objectives I already mentioned and then close it out. So for our case, we had a 30-year-old female G2 P1 at 34 weeks and 6 days in breech presentation. She was a transfer from an outside hospital. From their records, we noted that she first presented to them in August with fevers and chills, and she was incidentally found to be 25 weeks pregnant at that time. However, she left AMA before receiving the appropriate antibiotics. She represented to that ED in late October with pleuritic chest pain, and a transthoracic echo at that time showed an elevated right ventricular systolic pressure of 68. However, she again left AMA. She presented a third time on November 1st in mixed septic and cardiogenic shock. She was emergently intubated and sent to the ICU for stabilization with pressors and antibiotics. She was extubated the day prior to transfer to us for a high-risk C-section. So throughout her emergency visits, she had several UTOXs done, and they were all noted to be positive for opioids and methamphetamines. Just a side note, while she was on buprenorphine for her opioid use disorder, buprenorphine will not come up positive on a UTOX. It's only the synthetic opioids, which led us to believe that she was still abusing IV heroin. So this is the echo that we had done at UCH. So you can see that lovely 1.6 centimeter mass in the tricuspid valve flopping in and out of view. For us, we noted a right ventricular systolic pressure of 50, a flattened septum, which indicated RV overload, and enlarged right atrium with severe tricuspid regurgitation. The IVC was noted to be dilated without respiratory collapse, indicating a right atrial pressure of about 15. We also had a CT done, which noted emboli in the right lower lobe pulmonary arteries, believed to be septic emboli from her endocarditis. So a lot of consults were employed to get an adequate workup and optimize this patient. First off, she did receive betamethasone at the outside hospital before transfer to us. We had OB, cardiology, the pulmonary hypertension team, anesthesia, addiction medicine, and ID all on board managing this patient. She obviously had elevated blood pressures, as you can see here. Sort of the ongoing debate was, is this chronic hypertension made worse by her methamphetamine use, or is this technically pre-E with severe features? Regardless, we treated it with a nicardipine infusion. We diuresed her with Lasix per pulmonary hypertension's recommendations for a goal net negative 1 liter each day. We initially treated her infection with 2 grams of Ansef every 8 hours, switched to cefepime for about a week with the goal of having her then continue Ansef for 6 weeks once she was discharged. She was also maintained on her buprenorphine. Addiction medicine had her on 8 milligrams 3 times a day, and she was planned for a high-risk C-section in the downstairs OR, the AIP OR. So our anesthetic. First off, we alerted CT anesthesia, so a special shout out to Dr. Wilkie for being present with us that day. We also alerted the CT surgery team to be on standby just in case we had to emergently crash onto ECMO during the case. She got her usual pre-op Tylenol and antacids. We placed an arterial line as soon as she got into the OR, connected it to a flow track so we could monitor her cardiac output in her SVR. We then placed a combined spinal epidural at the L3-4 location. I used 1 cc at 0.75% bupivacaine, to which I added 25 mics of fentanyl, 250 mics of Duramorph. We then dosed the epidural with 8 cc's of 2% lidocaine with epi to achieve a T4 sensory level before incision. We also ran a propofol during the case, specifically during the arterial line placement, during the block placement and the start of the surgery. We paused it for the birth of her child so she could be present for that. However, she was exceedingly anxious, and we wanted to kind of help ameliorate that. At the end of the case, we had the surgeons place a continuous nerve block catheter at the site of the fan and steel incision, to which we connected it to an on-cue pump, and we ran 0.2% ropivacaine at 5 cc's an hour through that. At the end of the case, I also gave her IV Toradol. We kept her epidural for 24 hours post-op, knowing that she'd be pretty difficult from a pain control standpoint. We used a standard PCEA with a 0.1% bupivacaine with fentanyl. We ran it at a continuous 10 cc's an hour with demand dose of 5 cc's and a lockout of 20 minutes. We redosed it with Duramorph about 24 hours after placement before removal, and she was quite comfortable. So once the epidural was out, she was maintained on her normal Subutex 8 milligrams TID, as needed dilaudid, and scheduled Tylenol. So as we're all aware, there is an opioid crisis in the United States. This is nothing new. But what I want to hit home is that opioid crisis doesn't negate the pregnant population. They are also continuing to have access and abuse opioids as well. So approximately 20% of pregnant women are filling a prescription for an opioid. And of the women who are pregnant and abusing illicit drugs, nearly 25% are related to IV heroin use. Additionally, as drug trafficking between Mexico and Colombia to the U.S. is increasing and the infrastructure is building, the price of heroin has dramatically decreased, so that heroin is now cheaper than a lot of prescription opioids, and people are tending to turn to IV heroin for their addictions. Now, underlying this opioid use disorder is a very complex psychosocial pattern with associated mental health issues, lack of prenatal care, and often polysubstance abuse. So, maternal risks. Pregnant women with opioid use disorder are much more likely to smoke cigarettes, 93% compared to 22% of their non-opioid abusing counterparts. They also have a higher frequency of unplanned pregnancies, nearly twice as much. C-sections, preterm labors. And what I really want to highlight here is their increased risk for cardiac arrest or MI, which is related to their higher opioid requirements at the time of labor and delivery, which they get more opioids, can lead to respiratory arrest, can lead to cardiac arrest. The neonate also has risks. So they're at a higher risk for intrauterine fetal demise, growth restriction resulting in very low birth weight, which is 1 to 1.5 kilos, and low birth weight, 1.5 to 2.5 kilos. They're also at higher risk of cardiac defects, specifically hypoplastic left heart syndrome and gastroschisis. They have a higher risk of stillbirth. And another risk I really want to focus on is neonatal abstinence syndrome. So the incidence of this is exceedingly high in women who are either abusing IV heroin, opioids, or maintained on some sort of opioid replacement therapy. Nearly 90% require treatment for their withdrawal symptoms, and the constellation of symptoms you can see there. This also results in a higher length of stay, 17 days compared to 2, as high as 23 days if they require treatment with oral morphine. And if they do require treatment, the cost could be close to $100,000. So, treatment modalities. As you all are probably aware, there's methadone, and on the rise is buprenorphine. Additionally, over 21 states require that these women also have access to counseling and some sort of behavioral therapy to address the psychosocial components of this addiction. There's also the possibility of detox. However, detox poses a lot of stress to the fetus, which is noted in elevated epinephrine and norepinephrine levels. Additionally, if you think about it, a mother who's going through an acute withdrawal is in a really ramped up metabolic state. The baby's in that same state, but now in an oxygen-poor environment, which increases the risk of stillbirth in that population. So the American College of Obstetrics and Gynecology highly recommends opioid replacement strategies, so the message with detox is just don't do it. Now, I know you guys had a lovely Grand Rounds presentation last week by Drs. Lloyd and Schiavone, who talked about methadone and buprenorphine, so I won't belabor the point. But what I want to talk about is how these drugs change with regards to pregnancy. The metabolism and renal clearances are significantly higher in this population, so you'll often see multi-day dosing for opioid use disorder treatment, which typically in the non-pregnant population would be once a day. The typical range for methadone is usually anywhere from 80 to 120 milligrams a day. Additionally, methadone does cross the placenta, about 20% of the maternal dose. This is best noted in a study that tested or did non-stress tests on the fetus immediately prior and 1 hour after the mother received methadone. There was a 20% decrease in fetal reactivity. Additionally, methadone does appear in the breast milk, around 2 to 3%. However, current recommendations say it's okay for women to continue breastfeeding as long as they've remained compliant on their regimen. There's no concern for any ongoing illicit drug abuse. Buprenorphine, again, increased metabolism and clearance, not uncommon to see 3 times a day dosing. Typical dose, 12 to 16 milligrams per day. However, it can be as high as 24, which is what our patient was maintained on. Additionally, it does cross the placenta, only about half the amount of methadone, and a very scant amount appears in breast milk. So this kind of leads to the question, okay, great, well, which one is technically better? Well, there's a lot of things to consider. In terms of the mother, which is better for the mother, you can think about convenience. So methadone has a lot of strict requirements. Inductions are typically done in-house, inpatient, usually over 3 days. Maintenance medications are received on a daily basis from a certified clinic. Whereas buprenorphine, inductions can be done in a clinic setting, medications can be given for 1 to 2 weeks at a time, which gives the patient a lot more freedom, especially since they're often facing obstacles with regards to childcare, transportation, and work schedules. However, retention rates are a bit different. Much higher, about 20% higher in the methadone group compared to the buprenorphine group. That likely relates to the ceiling effect of buprenorphine. So some of these women definitely can experience some withdrawal type symptoms. So ideally, these women should be having very mild withdrawal symptoms at the initiation of buprenorphine therapy, which would aid in retention rates. The risk of overdose is obviously lower with the buprenorphine group. Now, with regards to the neonate, what I want to focus on is that buprenorphine can actually be better for the baby. One study I want to quickly reference is the mother study. They took 175 patients, randomized them to methadone and buprenorphine. What they found was an 89% reduction in total morphine required to treat the neonatal abstinence syndrome in children born to mothers maintained on buprenorphine. Additionally, they had about half as much time in the hospital after birth and a significant reduction in the amount of time within the hospital that was specifically dedicated for withdrawal treatment. So now I've given you all this information and you're wondering, okay, as the anesthesiologist, why do I care? Well, we care because these women have a significantly higher opioid requirement by the time that we see them, specifically with regards to C-sections. Those maintained on methadone require 70% more opioids after C-section. Those on buprenorphine require 47% more. Despite their tolerance of the analgesic effects to opiates, they do not have a tolerance to the sedative effects, which puts them at a much higher risk, and which is why we have to focus on our non-opiate adjuncts. One that I want to highlight today is the use of clonidine. As we all know, clonidine is an alpha-2 agonist, provides analgesia when it's given neuraxially. It does that by inhibiting nociceptive nerve firing and reducing substance P. It also doesn't have some of the harsh side effects that our opiates can cause. It does have some synergism with those opiates. It reduces the total local anesthetic required to keep your patient comfortable. But the concerns regarding this medication when it comes to the obstetric population relates to maternal hypotension, bradycardia, maternal sedation, and fetal heart rate abnormalities. One study that was done in the early 2000s compared bupivacaine solution with fentanyl, and they either added clonidine or they did not. What they found was that a lower total amount of epidural solution was required to keep the patients comfortable. They had less need for supplementation for breakthrough pain, less shivering, but they did have higher sedation scores. A more recent study done in 2018 looked at bupivacaine with clonidine. They excluded the fentanyl due to the fact that the last study may have had some synergistic effects between the fentanyl and the clonidine. So they looked at two different solutions of bupivacaine, two different solutions of clonidine. They looked at 14 patients, all maintained on buprenorphine, 7 in labor, 7 underwent C-section. They found the clonidine provided good to excellent analgesia. For the labor patients, 5 out of 7 avoided opioid supplementation after delivery. In the C-section group, the vast majority had pain scores less than 5 out of 10, and 3 out of 7 avoided supplemental opioid requirements. The side effects of hypotension were noted, obviously to be higher with the clonidine at 2 mics per cc. However, the hypotension only resulted within about 25% of their patients, and the need for intervention was the same as their standard solution as fentanyl, so it was deemed to be not quite clinically relevant. So in summary, what I want to focus on is that you come away from this talk knowing that the opioid use in pregnant population is on the rise. That population is not excluded from the current epidemic. These women who are either abusing IV heroin or opiates or maintained on oral replacement therapy, they are high-risk pregnancies. They're high risk because these women are at higher rates of abusing other substances. They have a higher rate of infection with Hep C, HIV, and a higher morbidity and mortality. There's also plenty of fetal risks, which we've discussed, developmental concerns, the neonatal abstinence syndrome resulting in longer lengths of stay and higher cost, as well as the possibility for stillbirth as it relates to acute withdrawal for the mother. So as more and more women are presenting to our labor and delivery unit on opioid replacement therapy, I want to stress that it's important to maintain them on their current regimen so as not to inadvertently push them into a withdrawal state, to always exercise caution with opioid supplementation, consider end-tidal CO2 monitoring, and to really maximize our non-opiate adjuncts, which we're already doing with our NSAIDs. And as more studies come out that show the benefits of clonidine and epidural solutions for the pregnant population, maybe one day we'll add it to ours. That's my references, and thank you everyone for your time. Yes.
So let's presume that the first time that your patient presented to the ED at 20-some-odd weeks of pregnancy that she chose at that point to go on methadone or buprenorphine treatment. Is there any data that says that there's a certain period of time that they need to be on that therapy in order for them to be more manageable for us at the time of delivery?
So they recommend that inductions actually start within the first term rather than the second term from what I had read. But really, if you can get them on a maintenance regimen to hopefully get them off of their IV heroin abuse at any point, it will be better for both the mom and the fetus. So while there are recommendations for what trimester is better, you can just get them on it, do it. In terms of her maintaining on her opioid replacement therapy and how her addiction can affect childcare. So I know we had addiction medicine and we had social work consulted for our patient and visiting with her each day, trying to prepare her. They tried to give her as much information as they could. However, she doesn't live in Colorado, so they couldn't exactly connect her with a lot of our in-state programs. Unfortunately, she left AMA from us as well, so there's only so much we could get through to her. All right, thanks everyone.
No, I think you unplug.
Oh, yeah. And get this out of your way, too. I thought you didn't touch that one. Yes. There we go.
All right, our second senior up to speak is Dr. Raleigh Anderson. She's going to be speaking about neurologic disease and neuroaxial anesthesia in the parturient patient.
Good morning. So again, I'm Raleigh. I'm also one of the CA3s. I'm glad Diana got everybody on the OB mindset, because I also chose an OB topic, neurologic disease and neuroaxial anesthesia in the parturient patient. Let's see. I do have some audience response questions, so if you guys don't mind logging into Poll Everywhere, you can either text to 37607 or log in on their website. They've worked about 90% of the time, so we'll see. Give you guys a few seconds to do that. If you do miss the login information, it pops up on the question slides themselves again. So you'll have another opportunity. So as far as the objective of my talk, I think I'd just like to start with a question. So how many of you have ever gotten a phone call, and I feel like it's usually 2 in the morning, patients presented to labor and delivery, they have X neurologic disease, they're in a lot of pain, can they have a labor epidural? I feel like I have definitely gotten that phone call. And 2 in the morning, I think it's a little hard to recall some information sometimes, so hopefully this will help clear up some of those answers for you all. So a little fact or myth. Administering a spinal or CSE to a parturient patient with MS can increase postpartum relapse risk. It worked. All right, so I'll give you guys just a little time to respond to that. And again, the login information is on the top for anybody who missed it. Alrighty. We'll see how we did. Okay, so a little bit of a split. So it is actually a myth, and we'll go through that. So multiple sclerosis is the most common disabling neurologic disease among young adults. It's twice as common in women, and it's usually diagnosed during childbearing years. The reason that's important is because it means it's likely that you'll see one of these patients sometime during your career that needs a labor epidural. The rate of exacerbation for patients with relapsing remitting disease is lowest during pregnancy, with the greatest reduction in the 3rd trimester. And then unfortunately, in the postpartum period during the first 3 months, they have a 50% increased risk in relapse. This is important because it means that symptoms associated with relapse may be wrongly attributed to your neuroaxial anesthesia. Fortunately, there were 2 studies that have looked at this. So the PRIM study was the first study. It followed 227 patients during pregnancy and for 2 years postpartum. They compared this data with the pre-pregnancy year and showed that epidurals were not predictive of the patient's number of relapses or their postpartum MS course as a whole. The only thing that they did find that was predictive of relapse was the number of relapses the patient had had in the pre-pregnancy year, the number they experienced during the pregnancy itself, and then their disability severity score, which was based on their neuro exam and their ability to walk. There was in a second study, which is the other study shown there. This was done in Italy. The nice thing about this study is that it looked specifically at epidurals and cesarean delivery and the effect on the patient's MS course. So this truly focused on that anesthesia component. They collected data on 423 pregnancies in 415 women between 2002 and 2008. They again followed these patients postpartum for at least a year and had a mean follow-up of 2.5 years, so quite a bit of time. Again, they showed no correlation with epidurals or cesarean delivery on frequency of relapse or their MS course. In fact, what they showed was similar to the PRIM study, that the number of relapses in the pre-pregnancy year, during the pregnancy itself, and their disease severity score, which was calculated a little differently, was most predictive of relapse. So when thinking about MS and anesthesia in these patients, the bottom line to remember, these patients can have neuraxial anesthesia. We don't have evidence that any type of anesthesia has been proven to increase relapse risk or negatively influence their disease progression. I think the most important thing you can do with these patients is talk to them about the experience or the symptoms that they may experience postpartum, how their relapse risk could change postpartum, and perhaps provide them with some open lines of communication after delivery so they can discuss any concerns they might have about their neuraxial with you. And then always document, document, document. So any symptoms that they've had recently or what their typical MS symptoms are like in your pre-op evaluation. All right, so next factor myth. Dural puncture is not safe in the parturient patient with idiopathic intracranial hypertension. This was previously called pseudotumor cerebri. This one doesn't seem to be loading. I'll try it one more time. There we go. And we had a few answers there. Not sure why I quit. Anyways, this is also a myth. I promise there's not a trend. I should not write multiple choice tests. Okay, we'll go to the next slide. Just having a little bit of trouble advancing the PowerPoint. Try it this way. All right, so some of you may be thinking, well, this doesn't really make sense to me. Patients with idiopathic intracranial hypertension have an elevated ICP. So with a dural puncture, aren't they at risk for herniation? And I think to really understand the association between a patient's intracranial pressure and their risk of herniation, it helps to look at intracranial compliance. So compliance is the relationship between the pressure and the three primary intracranial elements and their volume. So first you have the brain, the tissue itself, and the intracellular and extracellular water that make up the brain. It's relatively non-compressible and accounts for about 1,400 cc's of volume. You also have the CSF, which is about 150 cc's of volume, and it exists in a system of communicating chambers, and the communicating part is the important part, into the subarachnoid space, and then finally the lumbar cistern. And then you also have blood, of course, also about 150 cc's, and the amount of blood is influenced by vasoconstriction, vasodilation, the partial pressure of carbon dioxide, etc. So all three of these elements exist in the non-compliant bony skull, which means that an increase in the volume of one, for example, brain tissue, means that you have to have an increase or a decrease in the volume of the other. This results in sort of a zero-sum game, which is known as the Monroe-Kelly doctrine. The intracranial compliance curve helps to illustrate this. So on the bottom here, the slope of the curve is fairly flat, and this is because the body's compensatory mechanisms are intact. So again, for example, an increase in brain tissue can result in a decrease in CSF, and you can keep the pressure in the skull fairly stable. Unfortunately, as the slope of the curve starts to increase, that means that the body's compensatory mechanisms have been exhausted, and the CSF and blood can contribute to an increase in pressure, just like the non-compressible brain would. This means that the patient is then at an increased risk of herniation. So back to the idiopathic intracranial hypertension. It's a condition, like we said, with elevated ICP. We don't know why. It's also in women of childbearing age most common. So again, likely that you might see one of these patients that needs a labor epidural. Typically, the ICP is greater than 20 centimeters of water, has a normal CSF composition. It's not actually a contraindication to vaginal delivery or pushing, although some obstetricians may assist the second stage. And cesarean delivery is typically reserved for obstetric indications. The key thing to remember about IIH, if you can remember one thing, is that there's no obstruction to CSF flow. So if a dural puncture occurs, caudal flow of CSF rapidly occurs, and the pressure and volume in the cranium remain fairly stable, and the patient shouldn't be at risk of herniation. So when thinking about anesthesia in these folks, again, like I said, they can have neuraxial, especially a dural puncture. In fact, the adequate pain relief that these patients may experience from this decreases the ICP increase that they may have from pain and uterine contraction during the labor process. It also allows the patient to avoid opioids, hopefully, which can contribute to hypoventilation and hypercapnia, which can also increase your ICP. And then it avoids general anesthesia, which we know that during induction and emergence, patients are at an increased risk of increased intracranial pressure. And it also avoids having to instrument the potentially difficult airway of a laboring patient. There is also some discussion that CSF dynamics may be altered and single-shot spinals may not function as expected. So perhaps for a purely elective C-section, one of these patients, that's not your go-to. Epidural boluses can also transiently increase your ICP, so recommending slow dosing of epidurals, considering maybe about 5 cc's every 5 to 7 minutes. And then some of these patients will have VP shunts, so it's just also nice to know that VP shunts are not a contraindication to a labor epidural placement. All right, hopefully this one will work a little bit better. So Arnold-Chiari malformation type 1 is a contraindication to neuraxial anesthesia. And I'll hide those responses. Alrighty. So I can't say I'm absolutely shocked the split on this one is closer to 50-50. This, I think, is a true anesthesia answer. I think the answer is a little bit more of it depends. So Arnold-Chiari malformation type 1 is the most common. It's 0.7% of the general population. It's usually, again, diagnosed in adulthood. It involves displacement of the cerebellar tonsils through the foramen magnum, which unfortunately in these patients contributes to obstruction of CSF flow, which may affect their ability to compensate with changes in pressure and volume inside the brain, or inside the cranium. These patients can be asymptomatic or present with a range of symptoms from headaches and weakness, ataxia, extreme pain. They do have abnormal CSF flow and pressure gradient, so they can have syringomyelia. There are other types of Arnold-Chiari. They are generally more severe, types 2 and 3. They're diagnosed in childhood and associated with myelin meningocele and spina bifida. The definitive neurosurgical management for the type 1 patients is decompression. That decompression hopefully relieves any obstruction to CSF flow, meaning that these patients can have neuraxial if they've been decompressed and are asymptomatic. So you can treat those patients like any other patient that you might when considering a labor epidural. For everyone else, I think it's important to consult neurosurgery early, and hopefully they've had an early OB anesthesia consult as well. Specifically, patients with persistent symptoms following decompression, it's a little unclear why they might be having those symptoms, and so I think neuraxial in those patients is more of a gray area. And for uncorrected lesions entirely, that's probably going to be a true contraindication to neuraxial. So moving just a little further down the CNS system, Patients with spinal cord injuries, I was a little surprised by this number. So yearly 2,000 women with spinal cord injuries will get pregnant. Patients with lesions around T6 are going to be at risk for autonomic dysreflexia. So autonomic dysreflexia is uninhibited sympathetic activity following a noxious stimuli below the level of the lesion, which you can imagine pain from labor would account for that. This uninhibited sympathetic activity is going to cause a sudden severe rise in blood pressure. The symptoms the patients might experience from this include blurred vision, flushing, sweating, but it also puts them at risk for dangerous arrhythmias, intracranial hemorrhages, other effects from that severe blood pressure. It's important to treat it very aggressively by removing the stimuli and shooting for a goal systolic less than 150. So because of autonomic dysreflexia, neuraxial is very important in these patients, even if you think, well, if they have a lesion above T10, they might not experience pain from labor. They will benefit from that neuraxial from an autonomic dysreflexia standpoint. Also recommend placing an arterial line so you can monitor blood pressure closely, and then having easy access to antihypertensives. I don't know how many of you are up on the OB floor that often, but in an emergency, I can't imagine those drugs would be that easy to get. So maybe keeping those in your epidural cart. And lastly, along the line of the spinal cord, so spinal cord stimulators, placement in women of childbearing age is increasing. So you may see one of these patients. Currently, the device manufacturers recommend that these stimulators turned off as soon as the patient is found to be pregnant. Of course, there's some literature that's coming out showing patients who've left their devices on throughout the course of their pregnancy and had no adverse effects. But I don't think anybody's going to be conducting any studies on that anytime soon, so I don't imagine that device manufacturer recommendation is going to change. Hopefully these patients will have an early anesthetic consultation. That gives you the chance to talk to the responsible pain specialist about any questions you might have regarding the device. It also allows you to, most importantly, obtain imaging. Essentially, if the patient's lumbar space is free of any foreign objects related to that spinal cord stimulator, then they can have neuraxial. The picture on the bottom right is a patient who has a thoracic placed spinal cord stimulator, and she successfully had a labor epidural for her pregnancy, or labor and delivery. There's question about whether or not the leads are likely to migrate, especially with fast bolusing of the epidural for, say, a crash C-section. We don't have any evidence that they can move, so dosing those epidurals as you usually would, I think, is fine. There's also been question about an increased infection risk, and again, we don't know that that's true. We don't have any evidence for that. There are some folks who will give antibiotics prior to placing a labor epidural in these patients, but I think the jury is out as far as whether or not you should give antibiotics or not give antibiotics. I think it's just important to remember that if these patients do get an infection, it doesn't just mean an epidural abscess for them. It means explant of that device, which was probably contributing significantly to their quality of life. So just the key points. So for MS, neuraxial does not increase your postpartum risk. Counsel those patients clearly and consider having open lines of communication after delivery. For idiopathic intracranial hypertension, they can have a dural puncture, they can have neuraxial. Dose the epidural slowly if you can, and know that a single shot spinal may not function as expected. For Arnold-Chiari type 1, I would consider talking to neurosurgery early and hopefully having an early OB anesthesia consult. And remember that if these patients are decompressed and asymptomatic, treat them like anybody else as far as neuraxial. For spinal cord injuries, early epidurals and watch for autonomic dysreflexia and treat it aggressively. And then for spinal cord stimulators, use imaging to guide the possibility of neuraxial placement. All right. I just needed to thank Dr. Jason Papazian for helping me put this presentation together. I believe certainly some of them can. I mean, asymptomatic type 1 Arnold-Chiari malformations, they should be able to deliver anywhere. Spinal cord stimulators, I would not imagine would place you at high risk. Obviously, something like a spinal cord injury is going to be a high-risk patient.
So with regional anesthesia, when we have a patient with nerve dysfunction, we avoid doing a block because of the two-hit hypothesis. Coating nerves with local anesthetics can cause, worsening or permanent nature of their nerve dysfunction. So with MS, when you can get a patient comfortable with an epidural, why medicate with CSF? Why not just do a straight epidural? Why do a CSE or a spinal? And then my follow-up question is, those first two studies that you showed with epidurals, were those CSEs or were those?
So those specifically, I believe, were epidurals. I would have to check, but I think that they were specifically epidurals. I don't think that they were CSEs. So I guess, are you asking, is there any data showing that a spinal is safe versus an epidural?
Yeah, my understanding was that we know that an epidural is safe.
Mm-hmm.
We can't say for sure that a spinal is. So in the absence of like a stat section where you're having to choose spinal or general, in general, I just avoid the spinal and do a straight epidural.
Yeah, and I think that's a fine choice. I think also general anesthesia for that stat C-section is probably going to get you to sleep faster too, but so probably up to the attending physician at the time, I would think. I don't think we have any data that says a spinal would increase your risk, so I'm not sure that we can say that either.